It's like a constant war, and you wanna settle that scar, but you're bruised and beaten, and you feel defeated. This goes out to the heaviest heart. Oh, to everyone who's hit their limit, it's not over yet, it's not over yet. And even when you think you're finished, it's not over yet, it's not over yet. Keep on fighting, out of the dark into the light. It's not over, hope is rising. Never give in, never give up. It's not over, yeah, whoa, yeah, whoa. Oh, game, set, match. Time to put it in your past. Oh, feel the winter leaving. It's redemption season. Long live the young at heart. Cheers to a brand new start. We're revived and breathing to live a life of freedom. Oh, to everyone who's hit their limit, it's not over yet, it's not over yet. And even when you think you're finished, it's not over yet, it's not over yet. Keep on fighting, out of the dark into the light. It's not over, hope is rising. Never give in, never give up. It's not over, yeah, whoa, yeah. And life is a race we run, so run till the race is won. Don't you ever give up, no, no, never give up. Life is a race we run, so run till the race is won. Don't you ever give up, we will never give up. To everyone who's hit their limit, and even when you think you're finished. Oh, to everyone who's hit their limit, it's not over yet, it's not over yet. And even when you think you're finished, it's not over yet, it's not over yet. Keep on fighting, out of the dark into the light. It's not over, hope is rising. Never give in, never give up. It's not over, yeah, whoa, yeah, whoa, yeah, whoa, yeah, whoa. Oh, to everyone who's hit their limit, it's not over yet, it's not over yet. And even when you think you're finished, it's not over yet, it's not over yet. Keep on fighting, out of the dark into the light. It's not over, hope is rising. Never give in, never give up. It's not over, yeah, whoa, yeah, whoa. Oh, to everyone who's hit their limit, and even when you think you're finished. Oh, to everyone who's hit their limit, it's not over yet, it's not over yet. And even when you think you're finished, it's not over yet, it's not over yet. Keep on fighting, out of the dark into the light. It's not over, hope is rising. Never give in, never give up. It's not over, yeah, whoa, yeah, whoa, yeah, whoa, yeah, whoa, yeah, whoa, yeah, whoa.
Advocacy by Mary Secco. We are very excited because this is our second advocacy webinar, and we hope that you enjoy it and that you learn a lot from it. Okay, Mary Secco, I'm sorry, I'm having trouble opening the uh, I have it here. Mary is an epilepsy educator who has worked in the community for the past 22 years. She has published programs to improve the epilepsy knowledge of teachers, school-aged children, and people with new diagnosis of epilepsy. She is a patient advocate who has championed the rights of people with epilepsy, meeting with policymakers and elected officials at the global, regional, national, and international level. Mary is the Secretary General of the IBE and a member of the ILAE Global Advocacy Commission. She has been the IBE focal point at the World Health Organization since 2014. Mary has an undergraduate degree in political science and a master's degree in health information science. Today's learning objectives are to understand and address the culturally appropriate aspects and consequences of the diagnosis of epilepsy, including stigma, provide guidance on social issues, including school integration, work, legal, and related aspects, provide guidance regarding lifestyle matters such as driving, sports, alcohol, stress, sleep, and drug use, and non-adherence, and provide guidance regarding safety issues related to epilepsy. So without further ado, I leave you with Mary Secco. Thank you very much for joining us today.
Thank you so much for the wonderful introduction and for the learning outcomes. And I hope I don't disappoint, because when I embarked upon making this slideshow, I was looking at how we can advocate as an epilepsy community to improve outcomes. So I won't necessarily address all of those learning outcomes as they are stated, but by the end of this presentation, I trust you'll have the tools that you will be able to work towards those. So bear with me for a moment. I have no disclosures. So the agenda. Today I wanted to give an overview of some of the definitions of epilepsy and then planning your advocacy, because it's so very, very important that when we look at advocacy that we have a plan of action. We'll also look at advocacy tools, relationship building, the importance of investing in people with epilepsy. We'll talk about awareness campaigns, and give some examples of how different epilepsy groups in different countries around the world have approached advocacy and in action. We'll look at policy advocacy, because it's very important right now that we all understand that we've got a tremendous opportunity as an epilepsy community to work towards an intersectoral global action plan on epilepsy, which is being spearheaded by the World Health Organization. And then we'll have summary and conclusions, followed by hopefully some questions from the group. So beginning with definitions. Advocacy, it's an act. It's a process of supporting a specific change in behavior or policy. It's an activity that can be done by an individual or a group, and it in political or social systems. And it's different than awareness raising. Awareness raising is informing and educating people about a topic or issue with the intention of influencing their attitudes or beliefs, but they often go hand in hand. In other words, it's very important to raise awareness as part of our advocacy. Campaigning is another thing that you hear a lot about, and campaigning are the actions or the events or the activities conducted by people working together to seek or achieve change or raise awareness. So things like the 50 million steps that the IBE has just completed for Epilepsy Awareness Day. And all of our advocacy has to be bound together by strategy, which is a plan of action or policy designed to achieve a major or overall aim. So this is going to be a whirlwind talk. I've got lots of slides, but in the end, I will give you a link to something called the Advocates Toolkit, which has been developed by the IBE in partnership with the Band Foundation, which is for making epilepsy a priority in Africa. But if you're listening to this webinar from any other region in the world, the materials inside are as relevant. When we plan our advocacy, we always must begin by looking at the big picture, looking for information on what the problems are. And then we plan our advocacy, we take action, we expand our reach. And today I'm going to talk to you about some of the tools you can use to do that. The big picture. 57 writers, 38 expert reviewers, and information from 112 different countries was put into the Epilepsy, a Public Health Imperative document. It is a publication of the WHO, so the World Health Organization. It was launched in 2019 at our Bangkok Congress. And this book is what all advocates should read before they embark on an advocacy initiative. It's available in all 6 international languages recognized by the World Health Organization. The chapters in this book: global burden of epilepsy, leadership and governance, comprehensive healthcare response to epilepsy, access to anti-seizure medicines, the social response, misconceptions and stigma in epilepsy, prevention of epilepsy, and research on epilepsy. This is a must read for any advocate that wants to do work in the epilepsy space. The final chapter of this book is something called the Way Forward. And what the Way Forward tells us is that epilepsy needs to become a public health priority, and that further action is needed to address the global burden of epilepsy. The book also tells us that there are cost-effective and sustainable strategies to treat and defeat epilepsy, and that each and every one of us has a role to play, whether we're a community advocate like myself, a person with epilepsy, a parent of someone with epilepsy, a care partner to someone with epilepsy, a clinician, an EEG tech, a school teacher. We all have a role to play that can change the social outcomes and health outcomes for people with epilepsy worldwide. One of the things that I point out here is that the language in this document is very consistent. And if we all use this language, we would escalate and elevate our ability to talk about epilepsy consistently throughout the world. In this document, we talk about 50 million people of all ages around the world living with epilepsy. Often you'll see 65 million, you'll see different things from each region. When this book was put together, the epidemiologists looked at all of the world's data and said, this is a number that we can safely stand behind. And the WHO said, this is a number we can as well. So in our communication with policymakers, and when we speak about epilepsy, the more we use the same numbers, the same language, the more our message will resonate. This report talks about 75% of people living with epilepsy in low-income countries not getting the treatment they need, and the disproportionate burden that epilepsy has, in particular in Southeast Asia and Sub-Saharan Africa. And it talks about the 13 million disability-adjusted life years, the 5 million new cases a year, and the 0.5% of the global burden of disease coming from epilepsy. It talks about roughly half of people with epilepsy experience physical and psychiatric comorbidities that worsen seizures and reduce quality of life. When you use the language in this document, you'll see things like world disease burden, devastating global health concern. And you'll hear language like increased risk of premature mortality, sudden unexpected death, status epilepticus, accidents, drownings, unintentional injuries, and suicide. So why do I highlight this? Later on in my talk, I'm going to talk about how our message has to resonate with the WHO. And by talking about what matters to them, we will see change globally. The report talks about people and their families being targets for discrimination, human rights violation, and epilepsy resulting in poverty. But there's also a very positive piece to the report, which is that 70% could become seizure-free with appropriate use of anti-seizure medicines, which can come as low as US $5 a year, and that an estimated 25% of epilepsy cases are preventable. So there's the hope in our advocacy And this is the beginning of how we give our messaging. In the report are key actions for policymakers to improve access to medicines. And they're listed there, so you don't have to reinvent the wheel. In the report is a summary of preventable causes of epilepsy and appropriate interventions. Again, in the report. And in the report are the actions needed to defeat epilepsy. And defeat is a lovely, strong word that an advocate loves to use. But those actions can come from the individual level, from the societal level, and from the house system level. So again, refer to the report, because the number one place to begin your advocacy is looking at the big picture. The number two place for advocacy is looking at what tools are available to help you define your problem. So one of the documents that I'm going to use throughout this whole talk is that African toolkit, which again, I will give you a reference for at the end of the talk. But one of the tools in there is the 5 whys of getting to the root of the problem. And I like this tool because too often we identify a problem, but we don't know how to solve it. And this is a tool to help us do that. So often you'll hear in epilepsy, persons with epilepsy aren't getting the medications they need. Why? I think our mind races right away to things like, well, there must be a supply chain issue, or I don't know what it is. But when you ask the question why, you start to drill down to the base problem. Well, because local clinics do not order any stock. Well, why? Why would a local clinic not order stock? Because a clinic does not diagnose many people with epilepsy. Why? Because people with epilepsy don't go to the clinic. Why? Because they go to traditional healers. Well, we didn't expect that when we were looking at our problem and identifying our problem. So the point behind this slide is that the problem might actually be lack of knowledge that epilepsy is a treatable condition. It could be lack of trust in healthcare providers. It could be an inability of healthcare providers to diagnose epilepsy. It could be stigma, it could be fear, and it could be cost. So understanding what the problem is how we begin to advocate. Another tool in the toolkit for advocates is something called a problem tree. So you begin with the main problem, which is that big heavy trunk of your tree. And using the same example, persons with epilepsy aren't getting the medications they need. Well, this has an enormous effect. So we all see the effect, which could be that kids are denied access to go to school, parents withdraw their children for absenteeism because they're having seizures at school, and it's causing a real problem between the parent and the school community. It results in unemployment. We know these things. It's poverty, social isolation, injury, early mortality, discrimination, mental health, and suicide. But what's most important is understanding the root causes. And if the root causes a lack of knowledge about the condition, that's where we begin our advocacy. If the root cause is significant risk with disclosure, that the person lives within a community where it's not safe to stand up and say, I have epilepsy, then we might have to begin with legislative change. If the root cause is that they're living in an already weak healthcare system that doesn't prioritize prevention and treatment, we have to find ways to make prevention and treatment important to the policymakers we're working with. So when we do advocacy, we have to know who are we going to work with and who we're going to work around. So there typically are 2 types of stakeholders. There's your decision makers and influencers. So your decision makers can change laws or practice, they can allocate budgets, or they can decide where public attention is focused. And your influencers can help you reach the decision makers and convince them to make the change you want to see. So this chart actually is an example of the level of support and power of each of your main stakeholders. And in good advocacy work, you look at everyone that you're going to be working with. So a local ministry official might be powerful, but they may not be supportive of what you're doing. Whereas a person with epilepsy might be supportive, but not powerful, acting alone. So the arrows within this diagram show where different actors might be able to influence others to make a larger impact. So again, these are tools that we use when we prepare our advocacy. When we look to how we're going to advocate, we look at how to plan. And one of the tools that we use is SMART goals. So is it specific? Have you targeted a problem that's measurable? Is it attainable? Is it relevant? Is it time bound? So again, looking at these tools to write out how you feel you can attack the program or attack the problem. Another tool that we use when we look at advocacy is a pestle. So we look at the political situation. What is the current political situation in the community? Well, all of us are dealing with COVID. So this may or may not be the right time to meet a legislator or a policymaker and say we need more resources. Homeschooling with COVID might be a perfect time to talk to school based resources and say that you're not meeting the needs of these kids with epilepsy, and we need to work together and figure out how we can do a better job of reaching these kids. So sometimes the political environment creates opportunities, and sometimes it creates barriers. Economics. I know everybody is saying when we get out of COVID, how are we ever going to afford to put money into these areas that are so underfunded? But what can happen is that providing governments with economic reasons to save money by a different approach might be the answer to that. And later on, I will use an example of how we funded a full surgery program in the province that I live in based on an economic policy and an economic analysis. So social, what are the local perceptions of persons with epilepsy? And what role, and this came from the African book, but do traditional healers and religious leaders play? It's really important that you look at the social environment. Technology, if you're going to be doing your advocacy via technology, you need to ensure that people in the community that you want to reach actually have access. Are they holding cell phones, or is their primary way to receive information through radio? So again, not building big programs if it's not accessible to someone. And legal, what are the legal frameworks that influence persons with epilepsy? What are the key laws, practices, or rules? Because these are all very important. And I go back to my comment about stigma and fear. If it is not safe to disclose that you have epilepsy, then we must begin by looking at the legislation and changing that to make it safe for people. So what do I mean there? The IBE is working with the ILAE to look at lifelong driver bans. So in some places around the world, the English-speaking Caribbean, many countries in Asia, it's a person that has epilepsy, even when it's controlled, is not eligible for a driver's license. This creates a massive barrier, but more importantly, it tells people with epilepsy, don't seek help, don't seek care, because you might lose your license, and that's important to you. So there's ways that we have to look at advocacy and how we can change systems to help the greater good. So environmental, how will the weather impact your advocacy or any other environmental factor? So if you've got tsunamis and flooding, it's probably not the right time to try to address the epilepsy issues unless the environmental impact directly impacts the person with epilepsy, in which case it's the perfect time. So when you look at advocacy, what's really important is the planning. And I think I've stated that, and we'll give you tools after this talk. But it's important also that you identify the goal, you identify your objectives, you look at what you feel are going to be your results, and you work towards it. So there's a very, very important aspect of advocacy, which is planning the work that you want to change. So my next section is on relationship building. And this cannot be underscored either. So on the left with the lovely pink scarf is Susan Axelrod. And Susan Axelrod is the founder of CURE, which is Citizens United for Research in Epilepsy. And she's standing with Gardner Lapham. And Gardner is a trustee with the Band Foundation. Both of these women are passionate about epilepsy and have created opportunities to fund and to change the epilepsy landscape. And what makes them similar is that they're both moms of people with epilepsy. So Susan has an adult daughter with epilepsy, and Gardner sadly had the worst outcome in epilepsy and lost a child, her firstborn, to SUDEP. But they are passionate about making change, and this is so very critical. So when I talk about relationship building, we met with Gardner because Gardner also has a passion to do good work in Africa. She's a public health nurse by training and did several years doing public health work in Africa, and said to us, I want to see change in Africa. So together we have built a consortium. So run by the IBE Africa region, funded by BAND, and not only funded by the BAND Foundation that Gardner's involved in, but very much with Gardner's input. We have created a team to address the epilepsy as a public health priority in Africa. And the team includes members from the World Health Organization Africa region, from the African Union, from the African Disability Alliance, and from the ILAE Africa. Why do I say this? Advocacy shouldn't be a solo sport. Advocacy needs to be built around consortiums. We need to have many people involved if we want to see systemic change. And in this case, we are leveraging the voice all the time of people in Africa through our program there. We call it Utatizi, excuse my Swahili, but that means advocacy in Swahili. And through the endorsement of the BAND Foundation, we've been able to fund some terrific work in the Africa region that's actually paying great dividends. So one of the things that we've done in the Africa region with the BAND funding and with that consortium I just talked about was to develop the Advocates Toolkit for making epilepsy a priority in Africa. It was only launched this week, so it's very timely. But one of the key things when you talk about advocacy is that you need to give clear information. We talked about that with the global report to people so that they're all saying the same thing. So in this Advocates Toolkit, you'll see we've defined epilepsy. We've talked about the number of people. We've talked about 10 million people in Africa having the condition, 25% of it being cases being preventable. We've also been able to encourage another advocate, Her Excellency Dr. Joyce Banda, the former president of Malawi, to become an IBE Africa ambassador. And like Susan Axelrod and like Gardner Lapham, she's also a mom of someone with epilepsy. And this is what motivates her to do the great work she does. When you think of advocacy, education is the most powerful weapon you can use to change the world. And I borrowed that from Nelson Mandela, but I want you to know that your advocates and all of the work you do has to begin with a position of knowledge. I put in this slide because there's a lot of ways that we can increase the knowledge of people that care about epilepsy. So I think it was like 7 years ago, we did the first Young Adult Summit for IBE did for young people with epilepsy. We did this one in Washington, DC, and this was the 2020s that came to our program. They are representative of Canada, the United States, Puerto Rico, and the Caribbean. And each of these young adults had to put in an application to be invited to a weekend in Washington, D.C., where we did almost like a think tank. We asked them to tell us how we could change the world for young people using the advice of young people. So as I look at this picture, I know 2 of them are now medical doctors. One because her dad had epilepsy, the other because she lost a sibling to SUDEP. I know there's a PhD in this group, and he was looking at developing innovative technology because his brother had epilepsy. There are many, many adults in this group that have lifelong epilepsy and are tremendous spokespeople. And that's what we tried to do. So bringing together advocates and giving them the tools to become the leaders that make change is terrifically important for epilepsy. And again, it all begins by giving them the information they need to understand the condition and how to manage it. These are the families that we support here in my own community in London, Ontario. And each of these families has gone through one of our education programs called Clinic to Community. So upon diagnosis, our neurologist will send a fax referral to our community organization asking us to meet with the family. And during that meeting, we will go over an hour script interactively about what it means to live with epilepsy, what you can expect, what your treatment options are, when you know your child is drug refractory, What does it mean to be a surgical candidate? And we introduce all of these topics, and we talk to families about how we can help them manage the lifestyle, help them have their child succeed in school. But that investment in these families just pays huge dividends to us as a community, because they become our advocates. They become not only our advocates, but they become fundraisers. They raise money for our organization so that we can always be able to afford to pay a community-based educator. So we call these our clinic to community families. They all were seen in the clinic. They were referred to the community, and together they are champions, advocates. We also go into schools because it's so vitally important that we give up-to-date and accurate information to school-based children and their teachers, because it's the future is in these kids understanding epilepsy, but it's also the workplace of little people, and they need to be able to go to school safely, and they need to have compassionate and empathic classmates. So years ago, we wrote the Thinking About Epilepsy program. You can look it up online. It's evidence-based. And what we did through a randomized cluster control trial was prove that when we go into a classroom and we educate a group of young people, and in this case, we target grade 5, when we educate a group of young people, we improve their knowledge and we change their attitudes. And we've been using this program for years. Here, they're in the classroom learning about an EEG. There's usually an opportunity to do seizure first aid. We compare epilepsy to asthma and other conditions of childhood, and we get a fantastic response. And each year, we probably in our community alone see about 125 grade 5 classes to do this, and we've been doing it for a decade. Okay, there's also advocacy campaigns. So I mentioned earlier on the 50 million steps for epilepsy. We wanted to walk one step for every person in the world that has epilepsy. And we're very proud to say that through the IBE chapters, I think we tripled that. And next year, we'll just add to this campaign by providing more information. So a campaign and an awareness campaign are different than advocacy, but they can be used to advocate. Purple Day for Epilepsy is March 26th. And on that day, we will see different places light up. So this is Niagara Falls. I picked it because it's a Canadian national site, world site. But Purple Day for Epilepsy was made by this little girl, Cassidy Megan. Now, she's apparently going to be joining you in the future. And Cassidy is now a young adult. But she did this, I think she was in about grade 5, and she said to her mom, why does nobody in my class have epilepsy, and why is nobody talking about epilepsy? And I see these campaigns at school for stroke and cancer, and I want people to talk about epilepsy. So she's pictured here. The gentleman to her right is her member of parliament, but she's here with the Prime Minister of Canada. So here this little voice was able to leverage a big momentum by telling others that epilepsy matters to me and my family, count me in. And Canada has actually, by proclamation, made March 26th Purple Day for Epilepsy. And on that day, if you see the proceedings from our parliament, you'll see that they're wearing the purple ribbon to celebrate epilepsy awareness in Canada. So does it translate into money? Does it translate into change? I think it does. And I know we have great examples of that. At a local level, we raise lots of money through Purple Day, but more importantly, it changes families' ability to disclose. It gives them an opportunity to say to their neighbors, epilepsy matters to me and my family, and I'm going to give you a couple of facts about epilepsy so you understand what it is. So it's been a wonderful tool for us to change attitudes and knowledge about epilepsy. I wanted to just share some of the other tools that have been used. Finding new drug supply chains in Uganda and Eswatini as an example. So in Uganda, when COVID hit, the people with epilepsy, as they did in many parts of the world, became very isolated. Many of their appointments were canceled, and they didn't have access to their drugs. So the Epilepsy Association of Uganda partnered with faith-based nonprofit health centers and were able to bring anti-seizure medication into the country. So this is a tremendous act of advocacy where through this collaboration, over 1,200 persons with epilepsy were able to get their medication from 25 faith-based partnerships. So that's exciting. The same problem happened in Eswatini, but in Eswatini, they chose to go to the media. So the epilepsy organization in Eswatini went to the media, said people are without their drugs, it's very dangerous, and with COVID, they're isolated in their homes. And in this case, they partnered with the Civil Society Human Rights Accountability Board. And I say that because it created opportunity. So speaking up, advocating for the lack of medicines gave them a permanent position on a human rights tribunal within their country. And again, access to medicines, which is so vitally important. Another example that we like to use is the legislation to fight stigma in Colombia. So it began in 2002 and it passed its parliament in 2010, so 8 years later. So the message here is that advocacy is not always quick, and you need to be very, very persistent if you want to see change. But what they managed to do in Colombia is get a law passed that that protected people with epilepsy. So basically, if you weren't getting medicine or medical service and it was denied by a health office, you were able to say, well, there's a law, and this law says that I'm entitled to this, to these resources. And so that is an example I think that's wonderful. Multi-sectoral collaboration. I like this one, and I found this one in the Global Report. The Philippines League Against Epilepsy advocated with their government, and in 2002, they got a presidential proclamation that made the first week of September every year National Epilepsy Week. Well, they took that leverage and they've been able to start the trainers program for epilepsy, where neurologists go and train primary care providers on how to treat and diagnose epilepsy. They've been able to do some school-based programs. And just recently, they were able to put epilepsy under the Mental Health Act for the country. So again, terrific advocacy work that made great change. The one that I will share is one that we did here, Bill 161 for school legislation. It was based on our parents' concerns that their children with epilepsy that needed rescue medications were not getting it in school. And we were able to work with the diabetes, anaphylaxis, asthma to change the law in Canada. And now there's a mandatory plan of care and administration of rescue medications for all of those 4 conditions. So again, advocacy doesn't always happen on our own. These were examples where it happened with policymakers, happened with media, happened with using other health conditions, and happened using faith-based groups in churches. Another example, using economic policy. In Ontario, where I live, so there's 15 million people, and we have universal health coverage. There's approximately 21,000 people who are drug refractory and could be candidates for epilepsy surgery. And we asked the government, it started with Dr. Carter Sneed, a doctor, and it was well supported by patient groups in Ontario, asked the government to fund epilepsy surgery. And a cost analysis was done. The incremental cost seems really high. So it was $18 million a year over 5 years. We're talking about $100 million investment in epilepsy surgery to do 50 dedicated surgery beds. The reason I point this out is a lot of people shy away from advocacy, saying, well, they're never going to do it. There's no money in the system. Well, this effort showed that if they invested this money over 5 years, they would reap huge dividends, and it would cost less to have people with epilepsy in the province over a 20-year period. So the program was totally funded. The same happened with Neurological Health Charities Canada. And in this case, all of the neurological charities in Canada came together as one. So MS and Parkinson's and Alzheimer's and epilepsy and cerebral palsy and Rett syndrome. And we said to the government, you have a tsunami of, you have a a lot of Canadians that live with brain conditions, and you need to be better prepared to support us. And what they invested when we came with a collective request was 15 million to look at the prevalence, incidence, and impact of all brain conditions. And we've used the data from this over and over to get more grants and to get more improvements for people with epilepsy in Canada. In fact, one of the things that I always draw upon is that we were the second epilepsy after brain injury, second most costly condition for our government of Canada, and we never even knew that. Okay. So if you want to know more about what's happening in global health, please go to the ILAE website, because there is an epilepsy database. And on that database, you can see what others are doing in global health, but I mostly encourage you to add your programs as well. Policy advocacy is the last part of my presentation, and this is the chamber at the World Health Assembly. And what we have to keep in mind is 50 million people with epilepsy is a constituency, and we have to leverage that number because we deserve to see change. When you go and you meet, and this is the work that I'm doing right now with the ILAE, but when we go and we talk to about policy change, it's not about what we want necessarily, it's about what we want being embedded into programs that they've already acknowledged is important to them. So at the World Health Organization, the member states, which are the countries around the world, have all agreed that these are the 17 global goals for sustainable development that they want to see by 2030. They've agreed, they've signed, they've ratified this. So they would like to see universal health coverage. And they would like to see that reduce poverty. So I'll read just one line from what they're saying. Achieving universal health coverage is one of the targets of the nations of the world. Progress towards universal health coverage will make progress towards the other health-related targets and towards the goals. I'm babbling here, but good health allows children to learn, adults to earn, helps people escape from poverty, and provides a basis for long-term economic development. They have costed all this out. And they have said that about 100 million people are being pushed into extreme poverty, defined as living on less than $2 a day because they have to pay for healthcare. And over 930 million people, around 12% of the world's population, spend at least 10% of their household budgets to pay for healthcare. So what the WHO is saying, and it's been ratified by every country in the world, is that this must change. So when we're looking at advocating as an epilepsy community, we have to look at these priorities and say, where do we fit? So people that have epilepsy live in poverty, we know that. Number 3, target 3.4. By 2030, the world is committed to reducing by 1/3 premature mortality from non-communicable diseases through prevention and treatment and promoting health and well-being. So why is that relevant? Well, in our toolkit for Africa, we identify that 50% of the income of a family's household is being spent on epilepsy treatment. So we align right there. We talk in our toolkit that persons with epilepsy have up to 3 times higher risk of premature death, and they want to reduce premature mortality by 2030. And so we align beautifully. What we need is to keep going back to policymakers and tell them how well we align, because we can help them solve their problem. And this was identified by Dr. Red McGuee, sorry, terrible accent here, when he said that it is imperative that we substantially scale up global efforts to address epilepsy, because those sustainable development goals include targets of reducing premature death, which we know happens in epilepsy. And they also cost people with epilepsy to live in horrendous poverty. So we need to be messaging this in all of our conversations with policymakers in every region of the world. And if you're in a region of the world that's poor or a lower income country, you can talk about building a system. But if you're in a higher income country where I come from, you can talk about the obligation your government has to see this change. The other huge transformative shift worldwide is empowering people living with the condition to become the agents of change. They want to see us stand up and be counted. And that's why it is vitally critical that you invest as much of your efforts as clinicians, as a professional community in asking people with epilepsy that you meet in your day-to-day job to become advocates. Ask them to volunteer, ask them to stand up and be counted, because they are the change that will make. Invest in being on board of directors for your local epilepsy community organizations so they can work with you. I'm running out of time, but I wanted to put a slide in like this to talk about it's also important in advocacy that you know what your government is interested in. So as a Canadian, I know mine is interested in mental health, in child mortality, in their funding for the WHO. I also know that they're interested in women's rights. So when I think about having a conversation with epilepsy with my government, I want to address those points in it. I know that when my colleague from Japan speaks, he talks about an aging and elderly population and how he speaks about epilepsy and its impact on the elderly. So know what your country is interested in, and that will help in your advocacy work when you have your meetings. So in 2015, we had the global burden of epilepsy and the need for coordinated action as a resolution at the WHO. And since then, we have been working towards getting a global action plan. So this is us at the WHO in 2019, I believe it was 2019, and we did a side event. And at this side event, we took the opportunity to continue advocating, giving knowledge to the countries in the room about epilepsy and its impact on people living around the world. And I put the picture in there at the top right, because again, that's another mom. She's from Lebanon, and she flew to Geneva to join us to hand out brochures to ensure that people went to our talk on the side of on epilepsy at the General Health Assembly. So again, your advocates can be very well invested and hugely important in these efforts. So my last conversation is going to be about the global actions on epilepsy and other neurological disorders. In November 2020, the World Health Organization's member states agreed that we need to develop a 10-year intersectoral action plan on epilepsy and other neurological disorders. That when we do this, it needs to support universal health coverage. It needs to talk about the promotion of physical and mental health, prevention, early detection, care, treatment. The whole opportunity is being presented to us. So what's happening right now is that starting this week until April 10th, we are going to be asked as an epilepsy community to provide feedback on their consultation process. So you will be hearing from the ILAE and the IBE asking you to share your opinions on what needs to happen. And I put this in because from the IBE perspective, we're doing community consultations and they take about 6 or 7 minutes. They're very short. And we've only done the first one, but we'll follow up with another one. And we asked our chapters to rank their priorities because it's easier to be an advocate speaking with an informed voice if you've heard from your constituents, which are IBE chapters. So far, the data is in from 57 countries. And so far, 42% said, we need our national governments to have a political will to want to see change. The second most important topic for the IBE chapters is reducing stigma. We need to have collective action on how to reduce stigma. And the third is access to medicines. This gives us, and this is only 57 chapters reporting so far, but this gives us a huge opportunity to advocate using the voice of people with epilepsy. So in summary, there's lots of different advocacy actions we can take, but we'll be more successful if we build community groups. We can do awareness raising, mobilizing, campaigning, posters, flyers, stickers, t-shirts, videos, advocating for policy change for laws, practices, and budgets. Media, you can use the interviews, the social media, Twitter, Facebook. And I think it's the last resort to do escalation, protest, or march, but it's also an option for advocating. It's typically one that you only engage if you've got really a terrible situation where you can't have a collaboration and a conversation. So in conclusion, I know I've spoken really fast about things, and I know I've talked about a lot of different things, but my closing messages are that advocacy can happen at the local, the regional, the national, and the international level, and it's all. And whether you're doing it at any of those levels, you should develop a multi-pronged advocacy plan. You should collaborate. Don't do it alone. I tried to give you examples of doing it with other health charities, other health conditions, using other organizations like faith-based groups or the media. Be persistent. As we learned from Colombia, which took 8 years, and as we learned from the resolution from 2015 to 2020, advocacy is a process. Be persistent. And people with epilepsy are invested advocates. Nobody wants to see change more than they do. And so provide them with encouragement, training, support, and the opportunities to make change. And if you'd like to look at the advocacy toolkit where I took some of these tools from, please go to www.epilepsyafrica.org and you'll find the toolkit there. Thank you.
Thank you, Mary, for such a wonderful talk. I think we really learned a lot about what's going on in the world in terms of advocacy, and also what can be done with regarding this important subject. I have some questions for you that we have from the chat box. First of all, what is the applicability of the toolkit in other parts of the world? How can we apply this toolkit in other regions of the world?
That's a very, very good question. When we did it, we tried to, the toolkit will be used in all regions of the world. And if there is a desire to change it, IBE is willing to change it for each region. So when I say change it, the tools are used anywhere in the world. Those are not specific for Africa. But we talked earlier on about the information and the education. So what we would want to add to a local or a regional toolkit is information about prevalence in that area, the challenges that that area faces, the legislation that might be barriers for that area. And that's what we would be able to change. But it is totally usable for any region in the world. And this is just our prototype. We launched it this week because we had this consortium and the funding from the Band Foundation. Now, that being said, if we had an equivalent to a Band Foundation in every region of the world, we would be unstoppable, because the work that we're doing in Africa, funded by this organization, is allowing our chapters to mobilize. And what was challenging our chapters prior to this was having the resources to mobilize. So the Band Foundation has given those chapters money to do advocacy, money to target their governments, and each and every one of them are doing it in a different way. It's quite powerful. So bottom line is the toolkit can be used anywhere, and if there's an interest in adapting it to your region, send me an email and we'll look at how we can do that.
Perfect. How can we is there any other IBE material in Spanish that we could use, for example, in Latin American countries?
I'm getting the sun in, so I'm looking sun in at this stage. So sorry about that. Latin American materials. My answer is I don't know that. We're going to create the IBE surveys in Spanish, and we do. And I do not know that we have those materials in Latin America, but I think the one that would know that would be Thomas Massa.
Okay, perfect.
Okay.
You were talking about the importance of persistence in advocacy.
Yes.
How to persist without feeling discouraged when problems come or when barriers are ahead of you and you cannot tackle them as you would like to.
So part of that is creating that strategy framework. So knowing truly if you do your homework before you begin advocating, you've got a plan of action. And I can't overstate how important that is. So then you know that you're working towards those indicators, those small goals. And if they're smart goals and they're realistic, then you should be less burdened. It's when we have these big problems like, solve world hunger. How are we going to do that? We have, you know what I mean? We sometimes make those goals too broad. So if they're specific and measurable and they're relevant to the local community, we shouldn't be as burdened. But but we do lose people who give up because they say, I just can't do it. So build the consortium, build the group of people working together, because when you tire, hopefully somebody else doesn't, or hopefully a fresh person comes in and says, I'm going to take it from there. And that's the beauty of it. And that's what we're seeing in some of these initiatives, that other people are coming and saying, no, we should work, we should approach it from this perspective, and I can be the person that helps with that. But it's, I think that what happens is we give up because we think the problem's too big. So make the problem smaller and work on it. My pride in Ontario here is all the good work we've done in schools. Now we have mandatory plan of care. Now we have kids being educated. We have developed just recently something called an epilepsy toolkit that's evidence-based. We worked with neuropsychologists at Sick Kids to put in strategies for teachers. It'll be published very shortly. But what we're seeing is we've developed now this wraparound protection for those kids going to school. And our commitment is to put it in languages, French, Spanish, and have it be used around the world. And that's something that we need to also be thinking about, that feeds into your second question, is that we need to be looking at what the best materials are around the world and making them available in different regions and in different languages, right?
How can we improve transition clinics? Is a question that we have for you from the audience.
Yeah, transitions are a big, I'm not sure how we can do it on a global level, but my experience as someone who works for a local agency is getting the way where we could be improving transition clinics is getting the right people in the room, which includes your pediatric team, your adult team, and your parents who are transitioning their children. Because anytime you listen to the stakeholder or the person who has the most invested in seeing the system work right, they'll readily tell you what they think the flaws are, and they'll readily tell you what they want. And then it's our job as the team that's trying to build that system around them to listen to that. And so, and we should really watch out for how much we put on paper and not in practice. So you can write the best guidelines and develop the best toolkit and just put it someplace and think that you've solved a problem. You haven't solved the problem at all if nobody uses it. So it's transitioning, using some pilot patients to see how you have developed that system. Does it work? Is it meeting the needs of these people? What are the barriers? Typically at the adult end, unfortunately, who's receiving these families, what are their barriers? So again, it goes back to engaging the stakeholders who want to use the system, because they often have really good ideas on what they think a system could do for them and with them. But.
Perfect. Apart from education, how other strategies exist to reduce stigma that is such a burden for epilepsy patients?
In my opinion, the number one way to reduce stigma is to make each and every person diagnosed with epilepsy informed about their condition. And if they know about their condition and feel comfortable talking about their condition, then they are the best stigma reducers. So if you know that your next door neighbor has epilepsy and you are able to talk to them about epilepsy, ask questions, watch how they're able to manage to live well with the condition or not, you become an informed champion. So to me, it's targeting people with epilepsy so that they are comfortable talking about their epilepsy to others. I really think that's vitally important. And it's vitally important in a variety of ways. And I'm going to go on a little tangent here, but if you read blogs around the world, and if you read some of these websites that are readily available, and I'm doing a lot of work right now on looking at these websites, there's a lot of misinformation out there. So as clinicians, if you had a priority of giving consistent information in a systemic way to each of your patients, then they wouldn't have to rely on the information they're getting on the internet that may or may not be actually true. So what we're doing in the community that I work in is that if you're diagnosed at the pediatric or the adult clinic in our community, you're given a referral, and we sit and we go through epilepsy with you. And what that allows the person to do is ask their questions in a very comfortable environment, to not feel threatened by the answers, to cry if it's emotional, but to really be able at their own level to ask those important questions. And when you do it on an individual basis, you can look at things like health literacy, are they actually understanding what you're talking about? That's so vitally important. So instead, we treat, diagnose, we see somebody 6 months later and say, how many seizures did you have? Yeah, I could tweak that medication a bit. It's not that's not as bad as I'm saying it is, but often consumers or people with epilepsy leave feeling they have unanswered questions. So we need to find ways to answer those questions. And if it can't be done in the clinic, we need to have good materials in the community and a good referral program so that the community can fill that void.
Perfect.
Right.
We have another question. How clinicians or scientists help to establish specific patients' advocacy, freeing from the possibility of conflicts? I don't know.
Yeah, so many of, I don't know if I know exactly that question, but many of the IBE chapters around the world, especially in lower middle income countries, were started by clinicians. And that makes total sense. A clinician starts a group and they encourage their patients to belong to the group. And there are many benefits to having like an IBE chapter, for instance, in that you can get natural peer-to-peer support. You can use it as an opportunity to increase awareness. You can use it to train your family, not train, but give the information your families need to be advocates and to live better with the condition. It can move people towards choosing surgery or other treatment options at a quicker rate because they understand that that's the next step if the medication hasn't worked. What we fail to do, though, is once you've set that up, you've got to give the families the right to run it on their own. So where we don't necessarily do a great job is when these IBE chapters have been been running for 30 years and they're still run by doctors. That's not how an IBE chapter, in my mind, should run. It should be run by people with epilepsy, for people with epilepsy. And the role of the medical community is to support that. Bring people into it, be medical advisors. So if I write a brochure on epilepsy, on first aid, I give it to my local medical advisors and say, have I put the right information in here? Or if I have a situation where a family's coming to us and we don't know the answers, we go to our medical board and say, how are we to respond to this? What is the right answer? But other than that, our epilepsy community here locally is run by people with epilepsy, for people with epilepsy. And that's how you create a very strong patient organization. And it's a complementary voice to the ILAE, actually. So if the young adults in the IBE work with the young adults in the YES program, you could see a huge momentum happening. And I forgot to mention, we have the Golden Light Awards where we're trying to do that. So there's an opportunity for YES and the young adults in epilepsy in the IBE world to come together and work together.
Perfect. How can we encourage our patients? What are keywords that you say to them in order to encourage them?
So I always think about epilepsy as a chronic disease, and chronic diseases need self-management, and self-management means that you're going to have the best outcomes if you know how to manage this condition on your own, and if you understand how to make lifestyle changes. So what we talk about in the community is come to us and we'll help you with those lifestyle changes, help you to live well with this condition. I don't know very many people that don't want to live well with their condition, right?
Yeah.
And so that's what the message is when we encourage people to join their local agency. So those families that I showed, we did 1,500 individual family meetings last year. Do you know where we did them? We did them in the families community. Now that we're doing them all on Zoom, but they're sometimes in the evening. Why? Because mom wants to be there, dad wants to be there, grandma wants to be there, the siblings want to be there. We invite the extended family. That's very difficult for you to do in your clinic.
Yes.
Right? It's very difficult. Also, the clinic is running all day long. We'll meet with families in the evening. We'll meet with families when they want to hear the message. And the families in that environment can ask very personal questions and not feel stupid. And I don't say that people are stupid, but people often feel threatened that they don't know how to ask a good question. And there's a lot of literature behind this. There's a lot of literature behind the lack of information in people with epilepsy, and it's comparable to the lack of information in the community. So we know that it's not a household thing. We know that until you have seizures, you never really think about them. And until you have epilepsy, you have a lot of misconceptions too. So it's our role as community advocates to get people to understand their condition and how to live well with it. And that's usually what brings them into our office. That and social support, because people are afraid and they want to know that there's somebody else out there they can talk to.
Okay, thank you so much, Mary, for such a wonderful talk again, and for answering all these questions that can sometimes be very difficult, like, because to address, because there are so many things surrounding like what epilepsy means for a patient and how it can be tackled and how we can advocate so that these same patients are going to be themselves advocates too. So that was really wonderful. And I want to invite everyone to our next webinar next week. It's going to be with Cassidy Megan. She's the founder of Purple Day. We're going to have her here and her journey and how it is to really be an advocate from within. And so we hope to have you here in our next webinar. Thank you so much.
And thank you for inviting me. This is an honor and a privilege. Thank you very, very much.